Today, we're going to discuss the mental framework that I use for understanding triglycerides. And so this episode is classification only, no treatment. Treatment we will be doing next episode. There are 4 lenses that matter in clinical practice: level, etiology, particle type, and clinical risk orientation. And once you see triglycerides through all 4 lenses, every treatment decision in the next episode will feel automatic. Lens 1, classification by level. Mild. Mild is 150 to 199 milligram per deciliter, almost always VLDL driven, and the risk is cardiovascular. Moderate is 200 to 499, still VLDL predominant, still ASCVD risk. Severe is 500 and above. This is where chylomicrons appear. This is where pancreatitis first becomes a real concern. And very severe is 885 milligram per deciliter and higher. And this is true chylomicronemia. Pancreatitis risk rises sharply. Now, this first step tells you the biologic problem, either VLDL excess or chylomicronemia. Lens 2, classification by etiology. So there are 2 broad buckets: primary and secondary causes. Secondary causes are the most common, include insulin resistance, obesity, diabetes, hypothyroidism, alcohol use, simple carb excess, CKD, pregnancy, and a long list of medications. Most elevated triglycerides are due to secondary causes. Primary causes fall into 3 groups: polygenic hypertriglyceridemia, familial combined hyperlipidemia, and the chylomicronemia syndromes. When we're saying chylomicronemia syndromes, we're talking about multifactorial chylomicronemia and the rare monogenic form, familial chylomicronemia. So this second step answers the question, why are the triglycerides up? Step 3, classification by particle type. Every case sorts itself into one of 3 particle profiles: VLDL, chylomicron, or both. VLDL predominant. This is mild to moderate hypertriglyceridemia, and this is typical of polygenic hypertriglyceridemia, familial hypertriglyceridemia, and familial combined hyperlipidemia. Mixed VLDL and chylomicrons. This is severe hypertriglyceridemia, often multifactorial chylomicronemia, and levels are often over 500, sometimes over 885. Chylomicron predominant. This is the rare monogenic form, familial chylomicronemia syndrome. Triglycerides are almost always in the thousands from childhood. And this step answers the question, which particles are driving the number? Lens 4, classification by clinical risk orientation. There are only 2 possible clinical goals, and they divide the whole field: cardiac risk or pancreatitis risk. When we are thinking about cardiac risk, this includes triglycerides from 150 to 499 milligram per deciliter. Biology is VLDL and remnant particles. When we are thinking about pancreatitis, this includes triglycerides 500 and above, especially above 885. Biology is chylomicron accumulation. And this step answers the key question, what risks are we trying to prevent? So how I put it all together is I classify triglycerides by asking 4 questions. How high is the number? Why is it elevated? What particles are involved? And what risks are we preventing? Once we answer these, the treatment plan, which we will cover in the next episode, becomes completely logical. To make this easier to remember, I've organized everything into a clean reference table. Just sign up for the newsletter and I'll send you the link straight to your inbox. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, do not worry. I've prepared notes for you. Visit www.easyendoprep.com to sign up for the newsletter and have all the key pearls delivered straight to your inbox. You can also explore the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, one bite at a time.